Hello, my name is Dr. Gabriel Sotomayor, and I am doing this presentation with my mentor, Dr. Maria Salido. Here we present a case report entitled Viscoelastic Injection to the Acromioclavicular Joint for Acromioclavicular Joint Arthropathy. The objectives of this presentation are to discuss the viability of viscoelastic injection into small joints, specifically the acromioclavicular joint, from here on known as the AC joint or ACJ. The significance of this presentation is to provide an alternative for patients with significant ACJ arthropathy that cannot undergo surgery for ACJ arthropathy or cannot have a steroid injection to their ACJ. Some background. Shoulder pain accounts for 16 to 26% of self-reported musculoskeletal complaints. Of these studies, they have shown that the AC joint pathologies account for 12.7% of musculoskeletal consults for shoulder pain. The most common reason for AC joint pain has been found to be osteoarthritis, and it has been seen in 54 to 57% of patients with shoulder pain over the age of 50. Initial conservative treatments include nonsteroidal anti-inflammatory drugs and physical therapy. Alternative options include steroid injections and surgery of the AC joint. On average, studies have shown that the pain relief from steroid injections lasts on average 20 days, with greater than 50% of patients opting for surgery thereafter. Surgery and steroid injections are not without their risks. Contraindications for steroid injections include infection, recent vaccination, uncontrolled diabetes, uncontrolled hypertension, epilepsy, pregnancy, breastfeeding, and certain anticoagulants. Contraindications for surgeries are vast and include many the same as for steroids, on top of requiring one to be able to withstand anesthesia and the physical therapy required after the surgery. Steroid injections also have many side effects. The major ones include cartilage damage, infective arthritis, weakening of tendons, and temporary increase in blood sugar and blood pressure. In this study, we wanted to look outside of the literature of small joints and include methods utilized to treat pain in large joints. While steroid injections and surgery are options for large joints as well, alternative treatments have been found to be efficacious too. Gel 1, a viscoelastic hydrogel composed of cross-linked hyaluronate, has been shown to work for 26 weeks with one injection and can be repeated. In a study comparing WOMAC pain subscores of Gel 1 injection and phosphate buffered saline, Gel 1 had an average 20-point-millimeter change over 26 weeks, compared to 16-point decrease for phosphate buffered saline with similar side effect profiles. Major side effects of Gel 1 include skin reactions, knee weakness, stiffness, as well as dizziness. While the mechanism of hyaluronate injections is not known, the theory is that since the synovial fluid is highly composed of hyaluronate, this injection will act as a lubricant, like synovial fluid, to provide more cushion to the joints. For our methodology, this is a single patient case study involving viscoelastic injections in a patient with significant bilateral AC joint pain due to the inability to receive a steroid injection. So a little bit more information about the case. Here we present a case of a 67-year-old male with a history of chronic bilateral AC joint pain. He received regular steroid injections every 3 months for his pain that provided greater than 70% pain relief. On the day he was scheduled to receive a steroid injection, we noticed a Band-Aid on his arm and questioned him about it. He reported that he had just received a COVID vaccination right before the appointment. We told him that we would be unable to provide him with a steroid injection due to the possible interactions it might have on the efficacy of his vaccine. We then discussed with him utilizing a treatment that has been extensively utilized on large joints, that being viscoelastic supplementation. As he reported his pain in both shoulders was 9 out of 10, he stated that he would like to pursue any option that might decrease his pain. We then proceeded to use ultrasound guidance to inject 3 milliliters of Gel 1 viscoelastic supplementation, split up into 2 doses of 1.5 milliliters in each AC joint. After the injection, he reported that his pain had decreased to a 7 out of 10. He also endorsed an increase in range of motion in both shoulders. When he came back 2 weeks later for his follow-up, he reported that he received about 40% pain relief that only lasted a week, and after that week, he was back to his full amount of pain. Due to the less than optimal results, we ended up doing another set of steroid injections in his AC joints. So how does this contribute to advancing evidence-based practice? Well, this is a case presentation on examining a new treatment for AC joint arthropathy, the purpose of which is to explore alternative treatments for either people who cannot undergo the standard non-invasive treatments or to find an improved treatment. By exploring new methods, physicians may be able to offer more therapeutic options that can be tailored toward the patients and their comorbidities. In conclusion, the goal of this study was to investigate alternative treatments for AC joint arthropathy. While steroid injections and surgical repair have an extensive amount of research showing their efficacy, not everyone is a viable candidate for those treatments. In trialing a viscoelastic injection on a small joint, we wish to examine a third option with fewer systemic side effects. Our goal was to find a treatment that fewer people would have been excluded from that could provide lasting relief from their pain. The results of this case report showed that at least initially, viscoelastic injections can provide pain relief in small joints. While the amount of pain relief and duration were minimal, it's a step in the right direction. A possible limitation of the theory of this trial is that the AC joint does not usually have a demonstrable amount of fluid. AC joint fluid is typically only found in patients with severe osteoarthritis of the joint. It is therefore conceivable that the shear forces applied to the tiny joint are too vast to overcome the amount of cushion that a viscoelastic fluid could provide when compared to that of a large joint like a knee. Another limitation is that the literature only shows WOMAC pain differences and not VAS, or visual analog scale, like we assess in the clinic. Further studies could have been done to see if the results of this study with a larger sample size could have shown improved outcomes. Alternatively, studies could look into different forms of viscoelastic injections as well as increased volumes of injectate. If viscoelastic injections are not shown to be as efficacious as a steroid, studies could see if viscoelastic injections could be utilized as a bridge between steroid injections if steroid injections don't last as long as expected. Lastly, with all injections, a study with physicians more experienced with ultrasound may yield better results. Thank you very much for listening to my presentation, and I hope you have a pleasant day.